I'd really like to thank everybody for joining us today. This is actually the largest audience we've had for a lemonade stand. So Dr. Holt brings quite a crowd. So we're super excited and grateful for her joining us today. Since we do have a lot of new folks on the list, I wanted to give a little bit of background on MCI. So we are a 501c3 nonprofit organization that's focused on providing support for the development of an advocacy for non-hormonal male contraceptive methods. And a lot of the questions that we get right away are why we're focusing there, and it's because we saw a need for a focus on non-hormonal male methods, and there are a lot of folks doing good work already in the hormonal space for male contraception. So here we are, and I wanted to give a quick word about how these lemonade stand sessions came to be. So the community that we work most closely with is an exceptionally collaborative group of people, and anybody who sits in a room with me for 5 minutes has heard me say that multiple times. I feel very fortunate to work with the groups that we do. And they've spent decades building professional and personal bonds that really benefit the community. So we've attempted to kind of capture this idea of this expertise and these relationships in a term that we call team science. And that was really a term that came to be for us about a year ago when we had a convening of this community to talk about how we could be innovative and how we could really build an ecosystem to make these methods come to fruition faster. So in that time, you know, the group has continued to join because we've identified places where we need additional expertise and experience, or where there's lessons to learn from fields that are seemingly very disparate from our own. But it's been a real pleasure seeing the group grow. And so we kind of rode on that momentum as conferences were starting to be canceled due to COVID. And we quickly realized that we were going to be really missing the engagements that we were getting with this community face-to-face at different conferences. So we also took a minute to kind of think about the secondary opportunities that were presented by the COVID situation and quarantine, things like, you know, reduced travel schedules and a lot of our scientists not being at the bench quite as much or at all. So there was an opportunity to maybe engage folks in a different way. So we decided to really embrace the trope of making lemonade out of lemons, and we started our lemonade stand as a way of sharing information and addressing in a group setting some of the things that we wanted to learn more about and some of the things that we wanted to share. So we really wanted these to be more than just a webinar. We wanted it to be a split of information sharing and discussion. So these have been pretty informal to date. And so after Bethany's presentation, we'll open the floor to just general discussion, which will be interesting with a group this size, so bear with us. But we really want to try and hold on to that element if we can, thinking of just a room full of folks just chatting about, you know, their thoughts after hearing this information. Finally, I really think that I'd like to just offer a quick reminder and acknowledgement of the fact that while these lemonade stands were started in the context of the COVID environment, I don't think any of us anticipated sitting here on a morning like this with that being almost the least of our concerns. So I really want to acknowledge the fact that several of the folks on this call, including our presenter and our technical lead on this, Nika, are experiencing wildfires and the fallout from that very close to them. So it's a scary time and an uncertain time with respect to a lot of connectivity. We also have colleagues that are facing or have been dealing with the sort of onslaught of a Category 4 hurricane. So I promised myself I wouldn't use the term dumpster fire, but it's hard not to when we're talking about 2020 more generally, but things are challenging. So if we do run into, we've put in all sorts of contingency measures, but if we do run into any technical difficulties, please bear with us. So I think that having been said, it's really hard to think of a better fit for the spirit of the lemonade stands or team science than taking the opportunity to learn from our colleagues in the MPT space. You know, I'm really hoping that part of this will come as an opportunity for us in the non-hormonal male contraceptive community to start with the end in mind and think about, as we're developing these technologies, how we might be able to incorporate, and we being our grantees, of course, incorporate some of these benefits for our ultimate end users. So without any further ado, thank you all for joining us. Thank you, Bethany, for taking the time and the effort to put together this awesome presentation. And I'll hand it over to you.
Great. Thank you so much, Heather. Can everyone hear me? Can you hear me fine? Okay, great. It's just such a pleasure to be here with you all virtually, and thanks so much to Heather and the MCI for the invitation. I'm the Executive Director of CAMI Health, which is based at the Public Health Institute. Our headquarters is in Oakland, California, and since 2009, CAMI Health has served as the secretariat or the coordinator for the Initiative for Multipurpose Prevention Technologies, or the IMPT. I'm really delighted to have the opportunity to provide an overview of the field of MPTs and the work underway to advance the field. The focus of this MPT field to date has been on prevention options for women. So I'm really looking forward to exploring with you all the feasibility of MPTs for males. So before I jump in, I want to thank everyone for submitting questions ahead of the webinar. We'll get to those, as Heather said, in the discussion. Also, as things come up, I want to remind you that you can post your questions directly in the chat. We're also going to have some interactive polling questions. So next slide. Okay, yeah. So, just to provide you with an overview of what's going to be covered here. We're going to sort of review what MPTs are, their needs, and sort of an epidemiological overview of why these are needed along with male contraceptives. And then spend time really looking at the current status of MPTs in the pipeline with a focus on those that have a contraceptive indication. And then we'll have an interactive discussion. So multipurpose prevention technologies, or MPTs, are being designed to deliver multifaceted reproductive health prevention, largely focused on contraception and the prevention of HIV and other STIs. They really could revolutionize reproductive health by reducing stigma associated with prevention of HIV and other STIs by incorporating these features into contraceptives, which are less stigmatized. They could also help address increasing concerns about social inequalities in the environment by providing more varied contraceptive choices to help ensure that all children are planned, wanted, and born into healthy families. The ideal MPT products would be extremely safe, affordable, and easy to use. We also know that end-user needs vary greatly depending on their stage of life and the region and culture in which they live. So an array of prevention options are needed. So reproductive health risks are interlinked. Unintended pregnancy, HIV, other STIs share common risk factors, namely unsafe sex. The prevention approaches for these indications, however, have traditionally been in silos. Condoms are the only existing method, or MPT, that prevents these multiple risks, and new MPTs are needed to provide more choice and improve prevention. So I'm sure most of you are familiar with the statistics that I'm about to go over, but I think it's really important to revisit why innovative approaches for prevention, including MPTs and male contraception, are so very much needed. The world's population currently exceeds 7.7 billion, and it's estimated to reach 9.6 to 12.3 billion by the beginning of the next century. Unintended pregnancies account for approximately 44% of all pregnancies, with estimates in the US even higher at 45%. These unintended pregnancies present immediate and long-term effects related to health, poverty, education, and environmental degradation, among other critical global issues. So while contraception has been found to have an impact on these issues, condoms remain the only reversible method of contraception available for men. In 2017, the Male Contraceptive Initiative collaborated with an independent market research firm to conduct an online survey across a sample of 1,500 males aged 18 to 44 in the US. And according to their findings, 17 million men are looking for contraceptive methods that better fit their lifestyle and relationships. So STIs, or sexually transmitted infections, have been sharply increasing globally, with more than 1 million STIs acquired every day worldwide, according to the WHO. In the US, the rates of STIs reached an all-time high in 2018 with approximately 20 million new cases. According to the CDC, or Centers for Disease Control and Prevention, between 2017 and 2018, gonorrhea increased 5% to more than 580,000 cases. This is the highest number reported to the CDC since 1991. During the same period, chlamydia increased 3% to more than 1.7 million cases, the most ever reported to CDC. And the number of primary and secondary syphilis cases, which are the most infectious stages of syphilis, increased 14%. Again, the highest number reported since 1991. And really tragically, syphilis cases among newborns increased 40%. Herpes simplex virus, the most common of which is HSV2, is among the most prevalent STIs globally. And according to CDC, HSV prevalence is increasing among young people in the US. In some cases, STIs can have serious reproductive health consequences beyond the immediate impact of the infection itself. And this includes infertility and mother-to-child transmission of HIV. And, again, condoms are the only available method for combined prevention of unintended pregnancy and STIs, both for men and women. So MPT end-user preference studies to date have focused on women, and I thought it would be interesting to touch on a few of these studies to give you a sense of the type of MPT end-user research that is being done. So Ipsos Healthcare conducted an MPT market research study to assess the acceptability of MPTs among women in Uganda, Nigeria, and South Africa. The key objectives of this were to understand women's sexual behavior, attitude towards contraceptives and HIV, and to gauge the level of acceptability for 4 potential MPTs: injectables, implants, the intravaginal film, and rings. More recently, RTI International colleagues there conducted the TRIO and Quattro studies. These were prospective clinical and mixed method studies that included using discrete choice analysis to assess end-user preferences and use of different MPT product delivery forms among women in several different sub-Saharan African countries. A few MPT product preference studies have looked at US women, although at a lesser degree than studies that have focused on Africa. These studies have included cross-sectional online studies and studies using conjoint analysis, and have looked at women across the US, including those at high risk for HIV, STIs, and college students, and have indicated a potential interest in market for MPTs. Product-specific end-user research has also been done by MPT product developers with a focus on specific products in development to inform their product development processes, including formulation and delivery type, and they've used human-centered design and other approaches for this. And finally, the male contraceptive market study that MCI collaborated on that I just mentioned did look at STI concerns in their study population and is suggestive of men's interest in male contraceptives with an anti-infective indication. But additional research in this area would definitely be useful. So there are an array of MPTs in development that may better address the varying needs and wants of end users around the globe. And some of these are using innovative antibody technologies. And an increasing number of researchers are looking at non-hormonal contraceptive options in combination with anti-infectives. There are also fast-dissolving vaginal films, vaginal and rectal inserts, and gels in development. Some MPTs combine contraception with HIV prevention. Some combine contraception with the protection against other STIs, and others prevent HIV and STIs, other STIs, but allow for contraception. There are also new condom designs in development. So my team at the IMPT tracks the MPT products in development in an online searchable product database. The database reflects MPTs currently in development with active funding and provides information on the status of development, their targeted indications, the developer, the funder, and the funding type. For example, is the product being funded through an R01, an SBIR, et cetera? As of now, August 2020, there are 24 MPTs in development, preclinical or clinical, the majority of which are in preclinical. And of these, 17 have a contraceptive indication. So I now want to spend a few minutes reviewing the MPTs in development with contraceptive indication by delivery type, stage of development, and anti-infective indication. As the focus will be on MPTs with contraceptive indications, those with only anti-infective indications, so products with an HIV and HSV2 indication, for example, will not be covered in my remarks coming up, but you can find these in the MPT database. So as we step through these, I also want you all to remember that these are currently in development as women-controlled products, but some of these may have the potential to be repurposed for men. I also believe that some of the product developers working on these approaches are on this webinar, so can elaborate further during the subsequent discussion. So we're going to start by looking at the gels, the MPT gels that are in development. Both of these are non-hormonal contraceptives, or as some call them, hormone-free. One is in advanced preclinical development and has a contraceptive indication and an array of STI indications. And another is in phase 3 clinical stages of development. Microarray patches, oral tablets, and implants are also in development. The dual prevention pill, or the DPP as it's called, is in development by the POP Council and combines 2 drugs that are already approved by the FDA, an oral contraceptive and an oral tenofovir, and it's anticipated to reach the market by 2022 or 23. So this could be the first woman-controlled MPT on the market. There are fast-dissolving inserts in development that combine a non-hormonal contraceptive, amphora, with anti-infectives. There's also a film in development, and this is an intravaginal film that combines the antiretroviral islatravir and progestin and is in early preclinical stages of development. And so this slide here illustrates that the majority of MPTs in development are intravaginal rings. Of particular interest for this discussion may be those candidates that are outlined in red, notably the copper intravaginal ring and the product that combines human contraceptive antibody, VRCO1 and N6. These are female-controlled MPTs that also target male proteins. So we can, there's a lot here, but I think, you know, hopefully, you know, sort of this overview of the different products will give you a flavor of what's in development. And again, you can dig deeper into this by looking at the database. So now I want to, next slide. We want to step back for a few minutes and ask you to reflect on a few questions. Nika, are you set with the polling questions?
Yes, I'm launching right now.
Great. So hopefully you all can read these. So if you are a product developer or donor or investor, are you already considering ways to develop and support multi-purpose prevention products? If you can respond, that would be great. And then the second question is, you know, we're really interested in knowing who is out there that is developing anti-infective technologies. So if you have colleagues with expertise in that, we'd love to hear about it.
It looks like we have a few more answers trickling in, so we'll give it a few more seconds.
And Nika, I'm not seeing the results, so maybe you can summarize what we're seeing there. Or Heather, if you're seeing them. Aha, now I'm seeing them.
That's great, thank you.
Great. So Heather, do you want to summarize what we're seeing?
Yeah, for sure. First of all, are you able to see the results?
Yeah, now I am. It's going on and off. So.
Oh, okay, just to make sure. So for question one, if you are a product developer or donor/investor, are you already considering ways to develop or support multi-purpose prevention products? A little over half, 56% said yes, and that was out of 16 respondents. And then the second question, do you have colleagues with expertise in developing anti-infective technologies? 75% of the respondents said yes, and that was out of also 16.
Oh, that's great. Good, thank you. So those who have colleagues working in anti-infective areas, if you wouldn't mind, you know, reaching out to me and letting me know who they are or putting that in the chat, that would be terrific because we're really trying to engage with those folks. Okay, next slide. So as you probably gotten the sense, the MPT field is very complex and it requires bridging the silos of contraception, prevention of HIV and other STIs. It also requires multidisciplinary collaborations, including with supporting agencies, donors and investors, advocates, social behavioral, market researchers, regulatory agencies, and manufacturers. And this is so similar to the work that the Male Contraceptive Initiative is doing as well, which is, I think, why we really have partnered up and are collaborating so well. Lots of overlap. So upon the launching of the MPT field in 2009, the Initiative for MPTs was launched as a product neutral body. In other words, no horse in the race, to help bridge these silos. With initial support from USAID and then subsequently from NIH and the Gates Foundation and a few other funders, the Initiative for MPTs was launched. And so this is an illustration of our learning network model. As a central hub over the past decade, 11 years, CAMI Health has built this learning network that brings together multidisciplinary stakeholders from around the globe and serves as the first and only initiative dedicated to advancing the MPT field. We facilitate the identification of field-wide priorities and gaps and then strategies to address them by tapping upon the expertise of stakeholders, working through working groups, think tanks, convening, key informant interviews, and other mechanisms. So we have built this learning network by gathering and synthesizing data from network partners, disseminating the information out to partners, and then facilitating connections between partners. which, you know, working globally and through all these connections is challenging, but similar to what Heather is finding with the MCI colleague, the MPT network and partners are just incredibly collaborative and really working to advance the field, sharing information. So it's been a really great opportunity. So among the critical priorities and gaps identified through our network processes, we've identified a handful that are identified here. You'll see that looking down this list, that the identification of new hormonal contraceptive and anti-infective prevention APIs is a priority for the initiative for MPTs, as well as male-initiated MPTs. So to address one of our earliest priorities soon after launching the initiative, the initiative convened a small technical working group to develop MPT dosage form target product profiles. These TPPs were created for long-acting injectables, intravaginal rings, and on-demand products. And as the field has advanced, it may be time to really revisit these TPPs, including those for non-hormonal contraceptives, non-hormonal contraceptive MPTs specifically. Then outcomes from our prioritization activities include the identification of strategic actions for combining hormonal contraceptives with antiretrovirals for HIV prevention, and then more recently for non-hormonal contraceptives combined with anti-infective agents. For example, HIV, chlamydia, and other STIs. These were done through a series of stakeholder meetings and think tanks with technical experts, including many of you here on this webinar. And these frameworks have been published. So the framework on hormonal contraceptive MPTs was published last, I guess almost 2 years ago in the European Journal of Contraception and Reproductive Healthcare. And that for non-hormonal contraceptive MPTs was recently published in the Journal of Biology and Reproduction. And these are available through open access if you're interested. So this slide really illustrates the action areas identified for non-hormonal contraceptive MPTs. These include identifying the target populations and product preferences for these types of products. We need to stimulate innovative drug development, maintain a pipeline for the most promising product candidates. We also need to identify the investment and business case and rethink funding mechanisms, as currently the majority of the funding for the MPT field is coming from the US government. NIH, USAID, in particular, the Children's Investment Fund Foundation is now supporting this work also, but clearly to move this field along, new funding needs to come in and we need to message and strategize around that. Also, given finite resources, we need to define benchmark criteria to inform the go, no-go decisions so that the most promising early stage products can get through the pipeline from preclinical stages of development to the hands of women. Clearly, not all of these can get funded, and at the end of the day, we need to get the most promising ones into the hands of women. We also, number 6 is to enhance research collaborations and multidisciplinary expertise. Also important and critical is to address and look at the regulatory pathways, patenting processes, and manufacturing and commercialization. So while the focus of this activity for identifying non-hormonal contraceptive MPTs, the action areas, was on female-initiated approaches, outcomes can hopefully also help inform male-initiated non-hormonal contraceptives and non-hormonal contraceptives itself. So these publications, just wrapping up, are as well as a wide array of other published papers and MPT resources, are available on the IMPT website. The site includes a variety of open source resources, and you're welcome to go check it out. So with that, we are really working hard to keep our network partners informed and share relevant information. So please reach out to us or partners at MCI if you're interested in joining the IMPT listserv or getting involved in some way. So we now have a few final questions. Tanika, do you want to open the poll? Great. So I'll just read this here. So if you'd be interested in engaging with colleagues around learning more and brainstorming about how to develop MPTs, please respond here. Yeah.
There you go.
Great.
So, yeah, in answer to the question, most folks would.
Good. So MCI we'll follow up with that. That's terrific. Thank you. Then we have one more question that is actually an open-ended question, and we'd like to ask you if you can move to the next slide, Heather. So this one, we're really interested in what you all, having heard this now, what you consider the top 2 technical challenges that you see with respect to developing an MPT. And if you could enter those responses in the chat feature, that would be great. And you know, we can look at these as part of our discussion, and also hopefully this can help stimulate some questions that you might have that you'd like to bring up with the group. And since there are some product developers that are on this call, it'd be great to get you to weigh in too. So as people are answering, and you know, you can just continue, you know, typing your responses into the chat. You can go to the next slide, Heather, and you know, we'll sort of wrap this up. You know, I just want to say that, you know, as I reflect on you know, other public health challenges, you know, that we've all been dealing with over the years. Prior to 1971, childhood vaccinations for measles, mumps, and rubella were separate doses administered on varying calendars and dependent on provider motivation, similar to the access for prevention of HIV, other STIs, and contraception. With the licensure of the MMR vaccine in 1971 by Merck, millions of children's lives have been saved, and this also proved to be a good investment for Merck. So similarly, MPTs with HIV prevention innovations and other HIV prevention innovations have the potential to increase contraceptive uptake and reduce HIV infection and other STIs in the US and globally by bridging the silos. So, you know, with that, I want to thank everyone. You can go to the next slide, for your time and interest, and really look forward to our conversation that's going to come right up.
Thank you so much, Bethany. I'm going to start, I'm just calling out Greg here to give a little bit more information on one of his comments. We've gotten some great feedback in the chat, so thank you all for that. As we talked about, we really would like this to open up into a discussion, but I also want to be mindful of the fact that we did have some participants submit questions in advance. So I think what we'll do is maybe run through those. I think that'll only just take a couple minutes. We had 4 folks submit questions in advance, so thank you for those. So Bethany, are you good to go ahead and take those?
Yeah,
I'm sorry, I'll read them to you, but just did you want to take a deep breath before you?
Yeah, so do you want me to, I'm sorry, you broke out a little bit. Did you want me to address the ones that came in ahead of the call?
Yeah, I'll read them out. The first few I think are probably better suited for you. So
sure.
Okay, great. So I'll start out. Yana submitted a question from PHI, so thanks, Yana. What is the interest from investors, and can you ride the femtech funding wave? Excuse me.
Yeah, so that's a great question. And femtech is sort of a term that's being used to sort of represent innovations in technology around women's healthcare and in different ways. And so MPTs, in my experience in talking with femtech investors and other investors, MPTs, the concept still seems to be a new idea. And so challenges seem to be include the length of time that's needed to get a product from preclinical to commercialization, and that's the ROI. Femtech funding wave is definitely an important angle, but I think we're going to really have to think about enhanced messaging around this, and also a robust business case. And really, really think through, at what point in the pipeline, what products in the pipeline might be most attractive for these types of investors.
Great, thank you. So then I'll move on to our next questions. I've got two more for you. These two are from Damika from MSI. So thank you, Damika, for submitting in advance. The first is, what combination of contraceptive and HIV preventive efficacy levels would be considered a success in an MPT?
That's a great question. And ideally, contraceptive efficacy for an MPT will be as good as the highly effective methods now available on the market. And HIV prevention efficacy would be high as well, 70%. These are gold standards, right? The data does show that end user acceptability is going to be really key. So even if you have an effective product in the lab, at the end of the day, for it to really be effective from a public health point of view, we need to be looking at the social behavioral acceptability angles to ensure that there's end user uptake. And I also think that this is probably a good one to bring up, for discussion with other experts that are registered on this webinar.
Definitely. Hopefully these will also seed into the open conversation here in a second. So everybody be ready. We're going to be pushing you to chat. So the follow-on question that Damika submitted was, what would public health messaging look like for an MPT where neither contraceptive nor HIV preventive efficacy exceeds 70 to 80%?
Yeah, that's a really good one, and a challenging one as well. But I think that the messaging could include that even such MPTs could provide choice and options for those who do not currently use any prevention. So for example, those who are at risk for STIs or in HIV who don't use any prevention, perhaps due to stigma, but a combination contraceptive and anti-infective, could potentially reduce stigma and uptake and increase uptake. Again, another good one for the group.
Great. We have a couple here related more specifically to male contraception, which I can address quickly here. Bob Schmitz, thank you for submitting two questions. The first is, what are the thoughts of people in this field about when a viable male contraceptive will be developed? Is the horizon in years or decades? So the answer that comes to mind right away for that is yes, years and decades. The hormonal space is on track to actually have a male product on the market sooner, and that I would say is definitely at least under the decade realm. And I know there's folks on this call who can answer that question much better than I. But specifically for what we're working on at Male Contraceptive Initiative, we are looking pretty much in the decade plus range realistically. The second question is, what data, if any, are there about the likelihood of adoption of a male contraceptive by men? And that's a great question as well, and something that we're constantly working to enhance at MCI. So we submitted or published a consumer study in 2017, but it was done in 2017. It was actually published January of last year, that presents an opportunity to address the need of up to 17 million men in the US who would be interested in a non-hormonal male contraceptive method. So, again, that's limited to the US, and it was an initial study that we did. So it goes up from there. So our strong belief is that there is definitely an interest, and we continue to gather information and video and all sorts of collateral to try and really bring that message forward, because I think it's been underappreciated, the level of demand or interest that's out there. So I urge folks, Kevin on our communications team has really done a nice effort to bring sort of an empathetic view. So there's a lot of video content and a lot of content that's in folks' own words, in addition to our consumer study, that you can see what people have to say about this. So we have a YouTube channel. We post things on our social media outlets. And then we also have a second small study that we did with young people, because we're really interested in engaging them in this process, because they'll be the first to really benefit from these methods when they do hit the market. So there is a study and a report on our website that was a small qualitative exercise conducted by our colleagues at YTH, which stands for Youth Tech and Health. And that definitely demonstrated an interest as well. And then the last question is from Layla Caleb. So thank you, from the Center for Catalyzing Change. And then her question was specifically, what about long-acting contraception for men? Again, that's something we can take into the larger conversation, but it's definitely something that we're working on. The first thing that comes to mind in the non-hormonal space are vaso-occlusive products that our colleagues are developing that are reversible vasectomy, basically. So those are the long-acting methods that are closest to development in our space. So again, thank you to the folks who submitted those questions that are hopefully going to get the conversation going a bit here. We still have, it's 47 after, but I'm going to be bold and claim we have 15 minutes for discussion. So, I urge folks to unmute and open up their cameras and go ahead and jump in for some conversation. Who's the brave soul that's willing to jump in first?
You jump in.
Great, thank you.
Hi, my name is Dinah. I graduated from the University of Illinois at Chicago, and I specialize in human sexuality, so I've done numerous research. I am moving to Europe. I'm moving back to Europe, should I say, and I'm looking to connect with researchers in Europe so I can continue doing work there. So I'm wondering if you or anybody on board there has any contacts that they could share with me. I could put up my email if that helps.
Absolutely, we can help make that connection. I'm taking down that information. Yeah, and if you'll just share your email address in the chat, what we can do is also make sure that, we pass it on through our networks of folks that might not be in attendance today.
Okay, cool. Thank you so much.
I'm curious, so I don't believe you've been in any of our previous lemonade stands, Dinah, is that correct?
Yeah, I was busy with school because I graduated with 2 degrees, so I was kind of in 2 schools simultaneously for a while. So this is my first time here.
So well, welcome, and I'm kind of curious what your thoughts are as a newcomer to the space, especially when we're talking about multi-prevention technologies, and with your area of study, what do you think from sort of the social and relational aspects?
Well, I studied biology and psychology and gender studies, so I looked a lot at behavioral aspects as to why men wouldn't use birth control, and I'm in contact a lot with the people at the Kinsey Institute, for example. So it's a fascinating study, and whenever I talk to women about birth control, male birth control, they're always enthusiastic about any possibility for male birth control. They're very enthusiastic, in fact. So yeah, so I want to do research in male birth control if at all possible.
That's awesome. Well, welcome, and thanks for joining in.
Thank you.
there anyone else out there that has questions? I'd love to get into some of the challenges around development. I know that comes up a lot. I know, Greg, to put you on the spot, you mentioned that in the chat as well, but I'm just curious what specific challenges we might have. I know, let me pull up my chat window actually. Some of the things that were brought out, which are really helpful, is Dan, you brought up a really good point as well about trying to design a single trial to address both contraception and STI prevention. That would not be a small task for sure. So I'm curious, you know, if others have thoughts on that. In the interest of making lemonade, how we might, are there ways that we could design something, or is there precedent for a similar sort of situation where designing for multiple?
Hey, Heather, it's Lisa. Can I jump in?
Yeah, please.
You know, I think that gets to the concept of whether you're going to have two separate products that are put together, and one is for pregnancy and one is for one or more of the STIs, versus a single entity that is supposed to work at both spaces. And those just look like, to me, those are different programs and represent different challenges. I commented that I find it most attractive to consider one product that would do both, because if you're going to go down the development path for two products that, you know, that you put together, the development is really developing each one individually and then doing the drug-drug interaction stuff that needs to be done to see if you can put them together. So I don't know if Greg has any further comments on that, but you know, I mean, I think the most attractive option for, especially if the concept is to reduce stigma, is to have a product that does both without being two different entities.
That's great. I just noticed that Greg sent us that he had to drop off for another call, so.
Well, I think the issue, this is Dan Johnston, I think the issue with making a single product too is if then your trials will have to really cover both indications, and that, designing those so that you get them both powered to do both contraception and STI, I think is a very high challenge. So I think what some people will do is essentially they'll try to create their product maybe even stepwise, depending on if it's two separate chemical entities or, you know, something that can be merged. But the idea of making, you know, a pivotal trial,
yeah, I agree.
Both contraception,
right?
If
it's a single entity, it's going to do both. You're absolutely right. You would explore one of the indications first, and then, you know, add on the second indication. I completely agree. Mm-hmm.
Yeah, I think that's what some developers are planning on doing, is making it a two-step process. But then again, you're funding two pivotal trials again, but it's probably the better way to go right now, at least. It may depend on the product, but it seems like a better way to go is to do them stepwise.
Yeah, this is Don Will. I think the endpoints are very important when you do a clinical trial. Contraception has much cleaner endpoints and can move a process forward, whereas STDs have a much more less defined endpoint, which makes it much more difficult to both design and get good results for a clinical trial.
And another idea to consider is that if you're going to do a male contraceptive, right, especially a non-hormonal, you're going to have regulatory hurdles because it's something that's really been pretty much unseen in the past. I think the FDA is fairly comfortable having done a number of trials on hormonals, which lead to azoospermia, and they're very confident with using low sperm counts as a measure of infertility and potential contraceptive effect. That's not necessarily true for a lot of the non-hormonal methods. Very few that I can think of that are going to lead to azoospermia, but they're going to somehow affect sperm function. So my point is, as you're thinking of the contraceptive endpoints, you're going to have to be walking the regulatory agency through something that's new and, you know, largely unseen in the past. And I think that's going to make it a more difficult challenge. Obviously, you know, somebody's got to go first, somebody's got to drive innovation, but those first products that go through are going to, I think, have a really interesting interaction and an important interaction with the FDA. Because if you do it well, it'll clear the path for everybody else. If you do it poorly, it's going to make it a problem for those that follow.
That's an excellent point. Margaret, I see that Margaret is over.
This is Margaret Batten from the University of Utah. Here's a question about coordination between female and male. So presumably both female and male will want STI protection independently. And we might assume that they would even individually want contraceptive protection. What kind of coordination between male and female devices, can we call them, would be necessary? Any?
I think so. Bethany, do you want to try and take? I mean, there's tons of people who could take the way better than me on this call. So I think that's a great question.
Yeah, it's an excellent question. I think that was honestly one of the reasons we're having this webinar. This is really new territory for us to start thinking about MPTs for men, and how can we, you know, which of the delivery devices, you know, that are currently in development for women might be repurposed for men. Yeah, so I think, yeah, I'll stop there and see if there's others that want to take that on. But yeah.
Well, I think it's a question not so much about repurposing something from women to men, but assuming that both men and women would want their own protection for STDs. And this is assuming that couples are, you know, not necessarily long-term monogamous. They'd each want their protection for STDs and also presumably for pregnancy prevention. So does that need to be coordinated in any way, or do you just develop two separate things? One for women and one for men?
I think that, you know, just, you know, right here, we're having the MCI and the Initiative for MPTs collaborating, you know, and really trying to bring the different technical experts together to coordinate. I think it's useful to try to learn from each other. The other thing I'll add to that is, to your point about not repurposing, another thing that has come up from some of our developers and some of our experts in the MPT space is to look at delivery approaches that are being used for other diseases that might be applicable or useful to consider for delivering multi-purpose prevention technologies. So.
Great.
We have about 3 minutes left, so I think we have time for maybe one more question or one more discussion point. And thank you, Margaret, for that. And to Bethany's point, I think that ideally, yes, there would be that collaboration, and we do hope that this is sort of a setting the stage for that.
Yeah, collaboration between the male and the female individuals as well about what they're jointly going to use. And of course, it's a mistake for the female to turn over contraceptive control to the male. And also, you assume you want double coverage for both. And the question is whether that would be true for the STD part.
Well, I will put in a shameless plug for an MCI product here. So my colleagues Logan and Kevin established a podcast or produced a podcast, I should say, that was just released this summer, late spring, early summer. And I always struggle because there's no way for me not to sound biased, but it actually is well done. I did not do the production. Logan did all the writing, Kevin.
That's okay.
And that we cover this. So one of the things we talk about is there's an episode called He Said, an episode called She Said, and then an episode called We Said. And I think it's really important because we hear interest from both sides and, you know, different dynamics, whether or not you're single or in a relationship. So I would urge folks to listen to that. It's and it tells the story of male contraception, and it's a really interesting story. So I think it's fair to say any of the folks on this call would be interested in it. So
what's it called and how do we find it?
It's called Intended. And you can find it on our website, and Kevin also just put it into the chat. But it's on our website directly, or reach out to any of us and we'll be happy to direct you.
Thanks.
Yeah, let us know if you do listen to it. We love to hear feedback too, because we're going to be developing a second season. So
great.
Well, we're right at the top of the hour. I seriously thank you all. This has been our greatest turnout yet, and we're super grateful for all of you to take time out of your day and listen to this great talk by Bethany. And thank you, Bethany, for all the work that you did on this. and Nika, who you can't see in the background, who had a tremendous lift on this as well. So I hope you all enjoy the rest of your day, and just let us know if there's anything we can do or if you guys want to engage in any way.